Welcome back to the Masterclass, everyone. I'm Harshal, your lead instructor, and today we're tackling part 50 of our series. Let me tell you, today's explainer covers a truly pivotal lesson. We're stepping into one of the most specialized, fast-paced, and honestly fascinating areas of inpatient coding. So grab your notebooks, get focused, and let's decode the complexities of maternity and neonatal care together.
But first, a quick reminder. If you are enjoying this lesson, please like, share, and subscribe to this channel, and share it with friends for this free course on Decode Healthcare with Harshal.
Okay, let's dive into this. Here's our syllabus for today. First, a quick intro and recap. Then we hit MDC 14, covering pregnancy and childbirth, followed by MDC 15 for newborns and neonates. After that, we'll look at CDI specificity, and finally wrap up with a summary and teaser for next time.
Part 1. Intro and Recap.
So in Part 49, we really mapped out MDC 12 and 13, covering the male and female reproductive systems. Getting a handle on that anatomy and the specific medical and surgical partitions of the female reproductive tract was absolutely essential. That knowledge literally lays the structural foundation for what we're tackling today, the clinical journey of a maternity ward. We're shifting from that baseline anatomy into the physiological marathon of pregnancy, delivery, and neonatal grouping logic. The stakes are higher here, and the documentation requirements are incredibly precise.
Let's move into Part 2, MDC 14, covering pregnancy, childbirth, and the puerperium.
To code correctly here, you really have to master the ICD-10 PCS root operations. So the crucial point is distinguishing between delivery and abortion. Delivery is strictly defined as manually assisting the passage of the products of conception from the genital canal. That falls under root operation E. Abortion, however, is artificially terminating a pregnancy, whether mechanically or with an abortifacient, which falls under root operation A. Mixing these two up will completely derail your DRG. One signals a natural physiological conclusion being assisted, while the other is an artificial termination.
Now, how does the DRG logic actually partition these delivery methods? Well, vaginal deliveries, unless assisted by instruments, generally fall into the medical partition because they rely on the body's natural processes. But a cesarean section? That triggers a surgical DRG. A C-section is coded with the root operation extraction via an open approach. And the specific type of C-section, whether it's a classical incision or a low cervical incision, matters immensely. The extensive surgical resources, the operating room time, and the specialized nursing required for an open abdominal extraction dramatically impact the final relative weight of the DRG when compared to a spontaneous vaginal delivery.
For MDC 14, you absolutely have to follow a strict sequencing protocol. Step 1 is always your principal diagnosis, the primary reason for the admission. But steps 2 and 3 are where coders often trip up. You have to sequence mandatory secondary codes, the outcome of delivery, meaning whether it's a live birth or stillbirth from the Z37 series, and the exact weeks of gestation from the Z3A series. If you miss that gestational age or the delivery outcome, the DRG grouper will stall out. It completely breaks the grouping logic because the system literally cannot calculate the risk or resources without that vital timeline.
Beyond those basics, what really drives the reimbursement tier up in MDC 14? Concurrent procedures are a huge one. If a patient has a tubal ligation concurrent with their delivery or some unrelated OR procedure, the DRG weight shifts upward. Then, of course, we have high-impact complications and comorbidities, our CCs and MCCs. Conditions like severe preeclampsia or postpartum hemorrhage, maybe requiring a Bakri balloon for control, drastically shift the reimbursement tier. As a coder, you must meticulously scan those operative notes and provider charts for these exact details to make sure the true complexity of care is captured.
Let's move to and see how this builds into Part 3, MDC 15, newborns and other neonates, covering the perinatal period.
When it comes to the neonate, birth weight is literally everything. It is the ultimate driver of MDC 15 relative weights. The DRG system categorizes infants into various specific birth weight tiers: extremely low at less than 1,000 grams, transitioning to 1,000 to 1,499 grams, then 1,500 to 2,499 grams, all the way up to normal weight at 2,500 grams or more. A lower weight tier exponentially increases the expected resource utilization. Plus, discharge disposition plays a massive role here too. If a newborn is transferred to another facility for higher-level care or leaves against medical advice, AMA, that status directly impacts the final payment grouping.
Just like we see with adults,
Neonatal DRGs partition into major surgical versus medical, but pay close attention to those medical interventions. Take respiratory support, for example. A mechanical ventilator completely takes over a physiologic function by extracorporeal means. That uses the root operation performance. CPAP, however, only takes over a portion of that function. It's merely assisting. Therefore, its root operation is just assistance. This clinical difference dictates whether the infant lands in a highly weighted intensive DRG or just a standard medical management DRG.
Now, most babies are going to fall into the normal newborn DRG. But what pushes a case from a normal newborn to a neonate with significant problems? It's the documentation of high-volume conditions like jaundice, sleep apnea, or acute respiratory distress syndrome, ARDS. Even conditions like transient tachypnea, or being small or large for gestational age, SGA and LGA, are critical to capture. Documenting these specific conditions justifies the extra nursing care, the lab work, and the specialized monitoring that the baby required during their first few vulnerable days of life.
Part 4. CID and Clinical Documentation Specificity.
And this brilliantly illustrates exactly what happens when documentation lacks specificity in the Inpatient Diagnosis-Related Group, or IPDRG system. Think about the OB/GYN side. If a provider just scribbles down C-section without noting if it's a primary or repeat procedure, or misses the exact weeks of gestation, or fails to document fetal presentation like vertex versus breech, you just cannot assign the most accurate code. Vague terminology forces the coder to default to a lower-paying DRG or send out a query, which delays the entire billing process and just muddies the clinical picture.
You know, there's a stark difference in how we handle maternal versus neonatal documentation. For the mother, the coder's primary responsibility is establishing cause and effect linkage. You absolutely must explicitly link obstetric conditions to the pregnancy. For instance, distinguishing pre-existing hypertension from pregnancy-induced hypertension. For the neonate, on the other hand, you have to demand exactitude. We need precise birth weights in grams and clear clinical differentiation between major conditions like neonatal sepsis versus transient tachypnea of the newborn. Let's look at a real-world CDI query guideline to see this in action. ICD-10-CM simply does not have a code for late preterm infant, for a baby born beyond 36 weeks. So if a physician writes that, you can't just code it. The rule specifically states, do not assign a code for late preterm infant. Query the physician whether the newborn is small for dates or light for dates. This perfectly teaches us how to handle non-codable clinical jargon and transform it into compliant, actionable data that the system actually recognizes.
Now, what's really interesting about this next concept is how validating present on admission, or POA flags, actually prevents massive revenue leaks. If an infant or a mother develops a condition after admission, say a deep vein thrombosis, that condition is flagged with a POA of N. Because it's a hospital-acquired condition, it cannot be used to increase the DRG payment. Capturing accurate, specific MCCs that were actually present on admission is exactly what protects a hospital's revenue integrity, ensuring the facility is paid fairly for the true complexity they managed from day one.
And finally, Part 5, Summary and Teaser.
All right, let's wrap this up with your absolute must-remember takeaways. For MDC 14 obstetrics, your primary drivers are the exact gestational age, the delivery outcome, and capturing those high-weight CCs and MCCs, along with specifying the exact root operations for the delivery itself. For MDC 15 neonatology, the absolute king is birth weight, followed very closely by accurately distinguishing between medical interventions like CPAP assistance versus mechanical ventilation performance. Keep these drivers top of mind whenever you review these charts.
Next time, we're moving out of the maternity ward and jumping straight into the realm of systemic diseases. Here's a teaser for Part 51. How does the MS-DRG logic shift when we encounter blood, immunological, and myeloproliferative disorders in MDC 16 and 17? The sequencing rules are going to get even more complex, guys, so be sure to review your notes before our next masterclass.
Before we wrap up, I want you to ask yourself, how much revenue and clinical accuracy is slipping through the cracks at your facility simply because of one vague word in a medical record? The power to fix that is now in your hands. If you are enjoying this lesson, please like, share, and subscribe to this channel, and share it with friends for this free course on Decode Healthcare with Harshal. I'll see you in the next explainer.